cancer specialists or physicians to give you an idea about some of the cutting-edge treatments that are now beginning to make progress in the treatment of this disease. So there are many key challenges in moving treatment forward for mesothelioma. It is rare and regional. Certain parts of the countries and certain parts of the world will have more patients than others. Trials for this disease can be challenging to accrue, and the market for this disease is small, less pharma and less research funding. Unfortunately, the fundamentals of disease management are still unresolved, so that the roles of surgery, radiation, and screening are undefined and or controversial. And staging and radiologic measurement are problematic, as Sam described. Systemic therapy for this disease, the standard of care, has not changed in over a decade, although this will change very soon. And as you'll see, there are very few what we refer to as actionable targets. So let's step back. In my country, there are about 2,500 to 3,000 cases of mesothelioma in the US each year. There are about 5,000 cases a year in Western Europe, and this is an emerging problem in the developing world due to very lax asbestos regulations. I tried to find figures for Colombia, and I saw one that said there were 255 cases over 5 years. And then yesterday someone mentioned that there were 90 cases last year. So it's an uncommon disease in Colombia, but unless asbestos regulation is tightened, there certainly will be more cases in the near future. This is a disease that occurs anywhere from 20 to 60 years following asbestos exposure. Since in my country the regulations took place in the mid-70s, the incidence was thought to have peaked in around the year 2000, while in Europe it'll peak in about 2018. Reflecting occupational exposure, men are affected about 4 times as often as women. And in my country it is a disease of the elderly, with a median age of 74, and 72% are over the age of 75. At least 70% of these are due to asbestos exposure, about half of which are occupational, and about 20% are para-occupational. The husband is an insulator. He wears his work clothes home. His wife does the laundry, the kid sits on his lap, and they get mesothelioma. And about 30% of these cases are unknown, but not everybody remembers what they were doing 50 years ago yesterday. So if you take a good occupational history, you'll find more that people were exposed. Here you can see the relationship between asbestos consumption and the 20 to 50-year latency following exposure. So how do we get from this, the inhalation of asbestos fibers, to this horrible disease? Well, after inhalation, the asbestos fibers will translocate to the pleural space, where they will then cause persistent inflammation, cytokine production, and generate toxic oxygen and nitrogen-free radicals. There are a few other causes of mesothelioma. Most recently, we've discovered that germline mutations in the gene BAP1, a tumor suppressor on 3p21, will predispose to mesothelioma, uveal melanoma, cutaneous melanocytic tumors, and other cancers. Mesothelioma is thought to predominate with asbestos exposure. This is a gene-environment interaction. So if you have the gene for BAP1, then even a low level of asbestos exposure can cause mesothelioma. We also see somatic mutations of BAP1 in about 20% of mesothelioma tumors. Therapeutic radiation for Hodgkin's disease, testis cancer, and others can also cause mesothelioma. And less well determined is whether the SV40 virus that contaminated polio vaccines in the 1950s, whether or not that can cause mesothelioma. And it's an uncommon fallacy. Smoking does not cause mesothelioma. Many people think it does, unless one smoked the brand Kent cigarettes in the 1950s, when they actually had proxidolite asbestos filters. There are 4 major disease sites of mesothelioma. About 80% of these are pleural, 20% in the peritoneum, and rarely do they involve the pericardium, the lining around the heart, or the tunica vaginalis, the lining around the testes. Pleural mesothelioma patients will present with chest pain, shortness of breath, cough, weight loss, fever, and night sweats. Peritoneal patients will present with increased abdominal girth, abdominal pain, loss of appetite, and an umbilical hernia. The most common presentation for a pericardial mesothelioma is death. 70% are diagnosed at autopsy, and that's because this disease can cause congestive heart failure, heart attacks, pericardial effusion, constrictive pericarditis. A tunica vaginalis meso is most commonly presenting with a unilateral testicular mass. And while a variety of prognostic factors have been described, the most important prognostic factor for mesothelioma is pathology, what it looks like under the microscope. In epithelial mesothelioma, the most common subtype, has an average survival of about 17 months, whereas a sarcomatoid meso, which is the variant that gives meso a bad name, has a median survival of about 6 months, while the biphasic or mixed mesothelioma has a survival in between. So what about treatment? Well, let's start with surgery. The purpose of surgery for meso is a maximal cytoreduction, which is able to remove the disease down to levels which at the end of an operation hopefully leaves only microscopic residual disease and only minimal or preferably no macroscopic disease. The role of surgery for mesothelioma is very controversial. It is rarely performed in some countries. In most of the U.S., it is more widely accepted. The goal, as I said, is to remove all visible tumor, but surgery alone is not curative. I describe it to my patients like peeling the white stuff off of an orange. You can't get all of it off. The optimal type of surgery is equally controversial, and the decision is often driven more by surgeon bias than really by data. There are 4 major surgical options for pleural meso. The most aggressive is the extrapleural pneumonectomy, and that is an en bloc resection of the visceral and parietal pleura, the lung, the pericardium, and the diaphragm all in one piece, a very major surgery. That has been pretty much supplanted by what we call an extended pleurectomy decortication. That again removes both the visceral and parietal pleura to remove all gross tumor. If involved, it removes the diaphragm or the pericardium, but the lung remains in place. I describe it to my patients like peeling a grape in a box. Both the extrapleural pneumonectomy and the extended pleurectomy decortication are surgical options with curative intent, as opposed to a palliative partial pleurectomy, which just partially removes the parietal or visceral pleura for a diagnosis or palliation, but it leaves gross tumor behind. It does not affect the natural history of the disease, but it can make the patient feel better. In a retrospective analysis, there was no statistical difference in survival by procedure at any individual tumor stage. So the more aggressive extrapleural pneumonectomy or the less aggressive pleurectomy decortication had basically equivalent results. What are the key prognostic factors for this? Well, the most important is going to be histology. Epithelial is far better than sarcomatoid, and whether a person has surgery with palliative or curative intent. And I think the graphs show that better. So an epithelial mesothelioma is going to do far better. We generally do not operate on a sarcomatoid meso because they do so dismally. Again, surgery with curative intent is going to do far better than simply a palliative surgery. Other prognostic indicators include tumor volume, which is something that makes logical sense. The larger the volume is going to do more poorly, and whether you give adjuvant or postoperative chemotherapy or radiation therapy. What are the roles of radiation for this disease? Well, curative radiation, just doing radiation while the tumor is in place, you get more toxicity to the underlying lung than you do for the tumor itself. We can use radiation in the palliative setting, and it really can palliate the painful tumor masses that can occur, particularly if you leave a chest tube or a pleuric catheter into the tumor site for too long, then the tumor will crack through and seed those biopsy tracts. And for that, we will do prophylactic radiation to try to prevent that from occurring. We can give adjuvant or postoperative radiation after the extrapleural pneumonectomy when the lung has been removed. But if we've left the lung in after the pleurectomy decortication, it is for the most part not feasible to give radiation. There are some experimental approaches with IMRT that can spare some of the lung, but that needs to be done at very experienced centers. Now, as I said before, removing the mesothelioma is like peeling the white stuff off of an orange. You cannot get all of the tumor, so we do need to do something adjunctive, and that's why we use multimodality therapy. Surgery alone in this series had a median survival of 11 months, but when we added an additional modality, whether it was radiation or chemotherapy, that was extended to 20 months. And if we looked at the prospective multimodality trials in this disease, we can see median survivals ranging anywhere from about 1.5 years to about 2.5 years. Still not good enough. Now, pleural mesothelioma is what we commonly think about for meso, but it also affects the peritoneum, and that is a biologically somewhat different disease. When we look at historical series of meso, in the peritoneum, median survival was about 6 months. In the 1980s and 90s, when chemotherapy came along, or palliative surgeries, median survival was around 1 year. But in contemporary series with very aggressive local regional treatment, median survival for this entity can approach about 5 years. Why do we use aggressive local regional treatment in peritoneal meso? Well, the natural history of this entity remains confined to the abdominal pelvic cavity, with little invasion of the underlying organs, no metastatic spread until it's quite advanced. Now, while there's no level 1 evidence, compared to historical controls, this does appear to improve survival, and it is a preferred strategy for this disease. So what do? We first do cytoreductive surgery to remove gross peritoneal disease, and this can be an 8, 10, 12-hour surgery. Then we give hyperthermic intraperitoneal chemo, otherwise known as HIPEC, which delivers high drug concentrations intraoperatively to microscopic residual tumor. There are a variety of drugs that are commonly used, no real preference for one over another. And sometimes we'll also add chemotherapy, systemic or intraperitoneal, before or after. Now, one advantage of this approach is that many patients with peritoneal meso will have ascites, fluid in the abdomen, that is very, very uncomfortable and needs to be drained multiple times. About 90% of patients with peritoneal meso will obtain durable palliation of ascites with this approach. And here you can see somebody before the surgery, and 18 months later, no ascites fluid. When we are operating on a patient with peritoneal meso, we use something called the peritoneal cancer index that helps us identify the amount of tumor. And here you can see an abdomen which has what we call a PCI of about 20, or a middle amount of mesothelioma tumor burden. We'll then determine the extent of the disease postoperatively using a score called the completeness of cytoreduction score. And here you see a CC 0 to 1. Almost all of the tumor has been removed. When we look at prognostic factors in the peritoneum, the most important are A, gender. Women do about 3 times better than men. So women can live up to 10 years with this disease, where men live on average 3. The pathologic subtype, epithelial, again, is better, and the completeness of cytoreduction, how good a job your surgeon did, is very important prognosis. But when we look overall at the outcomes, the median survival is about 5 years, which again is very different from the disease in the pleura, where patients will live at best about 1.5 years to 2. What do we know about chemotherapy? Well, our best level 1 evidence from randomized trials for chemotherapy for mesothelioma is that an antifolate plus cisplatin improves survival by about 3 months, delays tumor progression by about 2 months, shrinks tumors 20 to 40% of the time, and helps patients feel better. So the trial that changed our outlook on the role of chemotherapy for meso was this single-blind randomized phase 3 trial led by my former partner, in which patients received either pemetrexed cisplatin or placebo plus cisplatin. And this led to pemetrexed being the only US FDA-approved drug for mesothelioma. And here we can see a slight but definite improvement when we look at these curves. So the combination chemotherapy shrank tumors in about 40% of patients, helped them live about 3 months longer to 12 months, and delayed the tumor growth for a few more months. Unfortunately, no drugs have been approved for mesothelioma since this pivotal trial was completed in the early 2000s. Other active agents for this disease include gemcitabine and cisplatin, an active combo in multiple phase 2 trials, similar activity to pemetrexed and platinum in a retrospective series, but no randomized comparisons, and vinorelbine, an active agent which showed a trend towards an improvement in survival over best supportive care in a small phase 3 trial. But clearly, we need to do better. So what are the most promising drug classes of the moment for mesothelioma? Well, these are the VEGF inhibitors, the drugs that block the blood vessels that feed the tumors, drugs targeting mesothelin, the checkpoint inhibitors of immunotherapy fame, and other molecularly targeted agents. So we've looked at angiogenesis inhibitors, drugs that block the blood vessels that feed the tumors, for many years in mesothelioma. For quite some time, these were the only drugs available to study, and we did a lot of Me Too trials that all came out with pretty darn disappointing results. All of them by themselves were pretty minimally effective. But fortunately, we didn't give up, and we tried them in combination. And so the first positive randomized trial since pemetrexed was approved was the MAPS trial. And this was a randomized phase 2-3 trial of pemetrexed cisplatin plus or minus bevacizumab, otherwise known as Avastin, a drug approved for many other tumors. And here you can see a nice separation between the curves in what we refer to as progression-free survival from 7.3 to 9.2 months, and an improvement in overall survival by about 2.5 months from 16 to 18 months. Looking at the results on this table, we can see an improvement in not merely progression-free and overall survival, but also an improvement in 5-year survival from 10 to 17%. Placing this trial in context, the addition of bevacizumab to pemetrexed and cisplatin significantly improves progression-free and overall survival. It yielded an expected manageable increase in toxicity and does not impair quality of life. And they did not provide response data. The authors of this study felt that this triplet would be a new treatment paradigm for pleural meso patients who are eligible for bevacizumab and not amenable to curative surgery. Now, bevacizumab is a drug that not all patients can tolerate, increases the risk of blood clots and bleeding and high blood pressure, and it is not safe for patients who are older. Now, this study, you might have noticed, had a survival of 16 months in the control arm. But the original trial of cisplatin had a survival of 12 months in the experimental arm. Why were the patients living longer on this control arm? And that's probably because of the strict eligibility criteria for bevacizumab, a lot of patients can't receive this drug, and only the best patients really can. And indeed, I think our supportive care and other treatments certainly have also helped patients live longer. So do the results of this trial change the standard of care for mesothelioma? Well, it is an option under the US NCCN guidelines. It has not yet been FDA approved, although it is approved in France and may be approved in several other countries. And I would say that while it is a new option, it is not applicable to all patients, and it is not a paradigm shift. But there are other drugs of the same or similar class that are also being studied. This is the LUME-MESO study that was recently presented. It's a randomized trial of pemetrexed and cisplatin with a drug called nintedanib. Instead of an antibody, this is a tyrosine kinase. And here we can see that the combination increased the response rate from 44 to 59% and improved the progression-free survival to 9.4 months and overall survival to 18.3 months. Again, getting up there with a nice separation between the curves in both progression-free and in overall survival. And that difference appeared to be even better in those patients with the epithelial histology. Thus, the current ongoing study is a 450-patient study that compares pemetrexed and cisplatin with or without nintedanib, and this should read out in a few years. So placing these VEGF inhibitors in context, we wasted many years on Me-Too single-arm phase 2 trials that were difficult to interpret. We saw minimal activity, and the inherent disease stability may have led to our erroneous conclusion of a treatment effect. But combinations with systemic therapy have shown greater activity, and MAPS, fortunately, is the first positive phase 3 trial since pemetrexed came along. We are seeing some promising early data with the tyrosine kinase inhibitor chemotherapy combinations. Unfortunately, there are still no predictive biomarkers with these drugs, despite countless attempts in this and many other diseases. Now, mesothelin is a potential biomarker target in mesothelioma. Nice logical name. It is a tumor differentiation antigen that's normally expressed on mesothelial cells, and it's highly expressed in epithelial and biphasic mesothelioma. And a number of agents are currently targeting mesothelin in clinical trials. And these are several of them. They are a variety of different mechanisms, including immunotoxins, chimeric monoclonal antibodies, antibody-drug conjugates, bispecific antibodies, vaccines, and CAR T cells. And I'll talk about just a few of them. So SS1P is an anti-mesothelin immunotoxin, and in a variety of sequential trials, the drug was fairly immunogenic, so they needed to add other agents to it to make it less immunogenic. I think that even those of you who are not radiologists can see from across the room that this drug combination yields some very dramatic responses as you move from right to left. And here again, from black to white, you can see very dramatic responses of this on a PET scan with this combination. And while this particular drug is not being developed further, son of it and a grandson of it are being developed, and I think it really is quite promising. Now, enetumab ravtansine is a fully human anti-mesothelin antibody that's conjugated to the drug DM4. And so what happens is that you have an antibody that interacts with the mesothelin on the surface of the mesothelioma cell and brings in the drug into the cell, and then you get cell death. In a phase 1 trial, half of the patients, 50% of the patients, had tumor responses with this drug as a single agent, and 90% of them had their disease controlled, which is pretty impressive for meso. And that led to this randomized trial of enetumab ravtansine versus the standard vinorelbine. Hot off the presses last month, a press release demonstrated that this drug actually did not meet its primary endpoint. I know the data, but it hasn't been officially released. So this was indeed a bit of a disappointment. We get used to that in oncology. But this drug, when given in combination with standard chemotherapy, actually yields some pretty impressive responses. And so it is still being studied in combination with standard chemotherapy. CRS-207 is an interesting type of drug in that it is a vaccine that's made via the bacterium Listeria. And so a very unusual approach to trying to target mesothelioma. This particular trial adds the CRS-207 Listeria vaccine to standard chemotherapy. And again, even if you don't know how to read a waterfall plot, you just by looking at all of those things going in the direction of down, that tells you that all of those tumors are shrinking pretty dramatically, again showing the activity of this combination. This is what we refer to as a spider plot. It tells you the timing of the response as well as how deep the response is. And again, they're almost all moving in the downward direction, showing again that this is working quite well. Now this particular company, small company, decided that although this was really quite active, that they didn't want to move forward with this combination because immunotherapy is all the rage these days. And so instead they are moving forward with the vaccine in combination with an immunotherapy agent, and it remains to be seen if that will be as active. Now, in lung cancer, we've been moving forward dramatically because there are all these what we refer to as actionable targets, EGFR, EML4 ALK. In mesothelioma, unlike these more readily targetable oncogenic driver mutations, the on-off switches that we see, in meso, these mutations are what we refer to as tumor suppressors, and those are much more difficult to target. The three most common of these are BAF1, NF2, and CDKN2A. So as we have emerging understanding of the biology of